In Epstein's anomaly, what we see is that the right atrium and the right ventricle. Okay, so it is the pulmonary artery with the right atrium, then you have the right ventricle. So the septal leaflet that is there of the gap, the thing between the right atrium and right ventricle, the septal leaflet in the tricuspid apparatus is shifted down. Okay, this is the most important thing that happens in Epstein's anomaly. The septal leaflet is shifted down. The posterior leaflet also can be shifted down. In some patients, the posterior leaflet is also shifted down. But the important MCQ that they ask is what is not shifted down is actually the anterior leaflet. It never is shifted down, it stays where it is. So to summarize once again, what I just suggested to you, what happens in Epstein's anomaly is the tricuspid apparatus separates the right atrium and the right ventricle. The leaflets that are there of the tricuspid, we have the septal, we have the posterior and the anterior leaflet. The septal leaflet is most commonly shifted down. That's the main problem that happens in Epstein's anomaly. In some patients, you'll also see the posterior leaflet is also shifted down. As the leaflets are shifted down, the area above, which would have been part of ventricle, imagine if these leaflets are shifted down, then this area that is there, all this area which would have been part of the ventricle now becomes part of the atria. Now, one more thing that is happening is, as I was telling you, that the anterior leaflet is not shifted down. This is a potential MCQ that they can ask. Okay, which leaflet of the tricuspid valve is not shifted downward in Epstein's anomaly is the anterior leaflet. The septal leaflet is, the posterior leaflet might be, the anterior leaflet is not. What the anterior leaflet, however, does is it creates a tethering, and this tethering kind of blocks up the pulmonary outflow, the RV outflow into the pulmonary circuit, decreasing in pulmonary perfusion. Most of these children, because of the functional blockade created by the leaflet, the antiseptal leaflet, the RV blood is not able to smoothly enter into the pulmonary artery, and for this reason, for survival of these children, generally a ductus dependency is there. So ductus patency is required, and not only that, most of the children also do have some amount of ASD, resulting in right to left shunting. So the right to left shunting is happening via the ductus, or it's happening via the atrial septal defect or a ventricular septal defect. These are associated defects that allow the baby to survive in Epstein's, and these defects are responsible for right to left shunting of blood, which allows for the, and don't forget, the RV is going to regurgitate blood in the right atrium. So right atrium is going to be on the relatively higher pressure, allowing the blood from right atrium to enter the left atrium. So these shunts are required for the survival, and also this is the reason why the cyanosis occurs. So what happens in Epstein's then is we are talking about an atrialized ventricle, or rather part of the ventricle becomes part of the atria. This makes the right atrium quite large in size. This large atrium is picked up in the ECG with very tall peak to P waves in the lead 2. So what are all the things that can happen in Epstein's anomaly? First of all, you'll notice that on auscultation, they're going to have a peculiar type of S2. This S2, particularly the septal leaflet, when it closes, it creates a snapping sound like a sail of a ship. So this is known as a sail sign. Sail sign is positive. The JVP, this is auscultation. Okay, the S2, when you look at the S1, the S1, the closure of the tricuspid valve, there's going to create, it's going to create a sound. That sound is basically because of the large septal leaflets of tricuspid closure. It creates a sound that is referred to as a sail sign. Secondly, you'll see that in the JVP, the CV waves are going to occur because the septal leaflet and the other tricuspid leaflets are not approximating. So they don't create a seal, and because they don't create a seal, a lot of blood from right ventricle regurgitates in the right atrium, and right ventricular regurgitation, as we already discussed in the JVP section, results in CV waves or giant V waves. Third is, in the X-ray, the right atrium is going to be quite large. Okay, it is going to result in a very large right atrium. This large right atrium is going to create a shape like a box. It's also referred to as a box-shaped heart in the X-ray. Okay, in the X-ray, you're going to see a box-shaped heart. However, overall, what we're noticing, there's a right to left shunt happening, mostly at the atrial level or sometimes at the ventricular level because of a VSD or an ASD. And all these are responsible for triggering decreased blood flow in the lung, and this decreased pulmonary blood flow, so varying degrees of pulmonary oligemia will be there. The ECG in these patients is going to show tall P waves, and this tall P waves in lead 2 is a marker of right atrial enlargement. Okay, this is denoting right atrial enlargement. We'll cover more of these aspects when we do the ECG section, but for now just understand that ECG is going to show tall P waves in lead 2, which is basically nothing but right atrial enlargement. Atrial arrhythmias are quite common because of the very large right atrium. Other atrial defects are also likely to occur. So atrial arrhythmias are quite common in Epstein's anomaly. So these are some of the important things to understand about Epstein's anomaly. So let me summarize the thing once again. The core defect is the septal leaflet of the tricuspid apparatus is shifted down, making part of the ventricle part of atria. The posterior leaflet also might be shifted down. The anterior leaflet, however, does not shift down. It's not displaced down. Rather, it creates a tethering and creates a functional blockade for the RV blood to enter the pulmonary circuit, creating pulmonary oligemia. Right to left shunting does occur either via atrial septum or via the ventricular septum. So either atrial septal defect is there or it's a ventricular septal defect, and this is the reason why the cyanosis occurs. The various clinical problems that can happen in this patients is you will see that CV waves can occur in the JVP. So the neck veins are going to be bounding pulsations. This is because of the large V wave. You will see the sail sign on auscultation because the S1, when you auscultate, the flapping sound of the tricuspid leaflet, this flapping sound of the tricuspid leaflet is heard like like the fluttering of a sail of a ship, and that's called a sail sign. The right atrium in the X-ray is going to be very large, creating a box-shaped heart. Pulmonary blood flow obviously is going to be decreased, so you get oligemia in the chest X-ray fields. The ECG is going to show tall P waves in lead 2, which is nothing but right atrial enlargement. Also, the echo obviously is going to be confirmatory, which is going to show part of the ventricle is now part of the atria. It's called atrialized right ventricle. All these are important features that one understands Epstein's anomaly. You can see the image over here. So what you notice here is the septal leaflet is shifted down. A large chunk of the right ventricle became part of the atria, and the right atrium is now become large. Don't forget, in the X-ray, the right heart border is formed by the right atrium, and the right atrium having become large, that's the reason why you get a large cardiomegaly in the chest X-ray. Okay, resulting in a large cardiomegaly, which I told you is a box-shaped heart. This leaflet that is there is going to create a fluttering thing. That's what we refer to as a sail sign. Most of these children will have an atrial septal defect resulting in right to left shunting at the atrial level, or sometimes rarely in the ventricular level, and these are how the cyanosis occurs. The pulmonary blood flow definitely is decreased in these children, and these are all the important things that you notice in Epstein's anomaly. This is an echo image showing the very large right atrium, and you can see the right ventricle is quite small in size, and a large part of the ventricle has become part of the atria. This is what I was telling you is the atrialized right ventricle. This is the X-ray. As you can see, the right atrium become quite large. You're seeing a cardiomegaly and Epstein's anomaly. The pulmonary vascular markings, however, are still very dark, suggesting of pulmonary oligemia. So in a cyanotic child, pulmonary oligemia is very easy to help us eliminate some of the options which come with increased pulmonary blood flow. So you should see decreased pulmonary blood flow. You should see a large heart kind of looking like a box, the box-shaped heart, and then you notice on auscultation the pansystolic murmur because of tricuspid regurgitation, and the other signs that I just mentioned. All these put together will help us diagnose that this is Epstein's anomaly. Moving next to tricuspid atresia. So this is another echo image showing the atrialized right ventricle. The septal leaflet is shifted down, as you can see over here. The septal leaflet is shifted down. The free right ventricle that is there is reduced. This part of the ventricle is now become part of the atria. It is called atrialized right ventricle. So these are all important echo findings in Epstein's anomaly. Now moving to the next thing, we are talking about either pulmonary atresia or tricuspid atresia. Both of them clinically look very similar because in both the conditions, the blood flow to the lung is reduced. It's either because the pulmonary orifice is closed or the tricuspid valve is closed. Either way, the blood coming to right atrium is not being cleared into the lung. Now, both look identical. The one major difference between pulmonary atresia and tricuspid atresia, you can see here that tricuspid valve is closed. This tricuspid atresia, making the right ventricle hypoplastic. In the other slide, that side, you can see that this is pulmonary atresia, and in this pulmonary atresia, the pulmonary zone is closed, and whatever blood is coming to the right heart cannot enter the pulmonary circuit. Both these conditions, the atrial septum is going to be patent, and this is where the shunting of blood is going to occur. Okay, so whatever blood is coming to right atrium, there's no other way how it can drain out except in the left atrium. So via the left atrium, it enters left ventricle, and via the left ventricle is going into the aorta, and this is through the ductus the blood is coming in, and it's basically that's how the blood is entering the lung. So what points that they ask in tricuspid atresia? So one of the things that they ask in tricuspid atresia, so in tricuspid atresia, what is happening is a simple schematic diagram explaining the problem. In tricuspid atresia, whatever blood is coming through IVC and SVC in the right atrium, it cannot drain into the right ventricle. The right ventricle is hypoplastic. Via the atrial septum, the blood enters the left atrium. The left atrial blood enters the left ventricle. The left ventricle is basically supplying both the circuits. It pumps the blood out in the aorta, and through the ductus, it is pumping the blood into the pulmonary circuit. So yes, this is another ductus dependent condition. And since the left ventricle is doing all the work, there's a major point that you need to focus on, and this is the main differentiator actually that will tell us that this is a person. This is a scenario where you're seeing tricuspid atresia, and that is the ECG. The ECG is going to show left axis deviation. Left axis deviation. So let me repeat it once again. Tricuspid atresia, what's happening? The blood comes through SVC, IVC into the right atrium. Right atrial blood cannot enter right ventricle because the tricuspid valve is atretic. The RV becomes hypoplastic. The blood from RA drains into the left atrium. As I already explained to you earlier with the fetal circulation, that the two conditions where atrial septum has to remain open is one is tricuspid atresia and the other is anomalous pulmonary venous drainage. Okay, particularly total anomalous pulmonary venous drainage. So here also atrial septum is open. The blood moves from right atrium to left atrium, left atrium to left ventricle via the aorta, and through the ductus it supplies the pulmonary circuit. So LV is doing all the work. RV is getting hypoplastic. This is going to shift the axis towards the left side, and the left axis deviation is a very important finding to tell you that this is tricuspid atresia. So in tricuspid atresia, how do we manage? The way we manage these children is in tricuspid atresia. One of the treatment is we can do a modified BT shunt, and you can see here again the BT shunt. The BT shunt allows, so basically whatever blood is coming into the right atrium, it is entering the left atrium over here. It cannot enter the right ventricle because that has become hypoplastic. So what we're trying to do now is get blood in the lung, and one of the ways how we can get the blood in the lung is creating a BT shunt, this toxic shunt. Another way how we treat tricuspid atresia is by creating a Fontan procedure. So basically, one of the things that we do is we bypass the right heart because the right heart is not pumping the blood; it's not doing anything. So what we do is we take the inferior vena cava or via the RV. We are creating anastomosis or collateral with the pulmonary artery. So this is a pulmonary artery, this is the inferior vena cava. So we're connecting up the inferior vena cava to the pulmonary artery. This is known as the Fontan's procedure. When we connect the superior vena cava to the pulmonary artery, this is known as the Glen's procedure. So Glen's procedure and Fontane's procedure. So basically, the blood from SVC, IVC normally should have come to the right atrium. Right atrium blood should have gone to right ventricle. Right ventricle should have put the blood in the lung. We are bypassing the right heart completely. We are getting the blood from IVC draining into the pulmonary artery. The blood coming from SVC draining to the pulmonary artery. This allows pulmonary blood, the pulmonary circuit to work. So, but rather, pulmonary circuit is picking up blood from SVC, IVC. It's completely bypassing the right heart, and the whatever blood is coming into the left ventricle obviously is getting pumped out in the aorta. So this is what is referred to as the Fontane's procedure. Okay, so this is one of the ways how we treat tricuspid atresia. As we look at the Glen's is nothing but SVC to pulmonary artery, and Fontane's is nothing but IVC connected to the pulmonary artery. Next, we're looking at conditions that are associated with increased pulmonary blood flow. One of them is the total anomalous pulmonary venous drainage, or total anomalous pulmonary venous communication. Okay, total anomalous pulmonary venous communication, or total anomalous pulmonary venous drainage. Now, what happens in total anomalous pulmonary venous drainage is that whatever blood is coming from the lungs, this blood normally should form the pulmonary veins, and this pulmonary veins actually go in the left atrium and they enter into the left atrium from behind. But now the pulmonary veins are not opening the left atrium, and the pulmonary blood rather drains back to the right heart. Now, how can it drain back to the right heart? There are various mechanisms. One of the mechanisms is that the blood from the lungs is draining into something called a supracardinal vein or a vertical vein. This vertical vein comes and joins the superior vena cava. So this vertical vein joining the superior vena cava, this is one of the ways how the blood from the lung is able to drain in the right heart. This is what we call the vertical vein. And this vertical vein, pulmonary veins are opening into it, and it is draining into the superior vena cava, and this is what we refer to as supracardiac type of TAPVD. So broadly, we classify the total anomalous pulmonary venous drainage into supracardiac type, cardiac type, and the infracardiac type. Okay, supracardiac, cardiac, and infracardiac. Supracardiac, there are two possibilities. Either the blood flow from the lungs, the pulmonary veins, drain into the vertical vein that goes and drains in the superior vena cava, okay, via the vertical veins. That is one possibility. The other possibility is that the pulmonary veins can directly open in the superior vena cava, okay, directly into superior vena cava. Both these, however, are supracardiac type. So ultimately, the pulmonary flow is entering the SVC and entering the right atrium. Cardiac type is when the pulmonary veins are opening into the right atrium via the coronary sinus behind the right atrium. So directly putting the blood in the right atrium is called cardiac type. Infracardiac type is pulmonary vessels are now passing through the diaphragm and opening into the inferior vena cava. They're coming and opening in the inferior vena cava. So either opening in the inferior vena cava or opening the portal circulation. This is infracardiac type, and infracardiac type generally has got the worst prognosis because here the vessels, the pulmonary veins are passing through the diaphragm opening below, and this is either opening in the inferior vena cava or opening in the portal circulation. So worst prognosis generally is the infracardiac type, and worst prognosis in infracardiac type is mainly because the obstruction is very high likely in infracardiac type of total anomalous pulmonary venous drainage. So to summarize once again, what is happening in total anomalous pulmonary venous drainage? There are three categories of total anomalous pulmonary venous drainage. The pulmonary veins are either coming back into the draining back into the right heart via the superior vena cava, and when it's draining back via the superior vena cava, then it's going through the vertical vein. Through the vertical vein, it drains into the superior vena cava. This is known as supracardiac type. Or the pulmonary veins that are there can directly open into the superior vena cava. This is another supracardiac type. So ultimately, if the blood comes back into the right heart via SVC, that's called supracardiac type of total anomalous pulmonary venous drainage. If the pulmonary vessels open directly into the right atrium, that is called cardiac type. And when the pulmonary veins open below the diaphragm, either in the IVC or in the portal circulation, that is called infracardiac type. The most common type among all these is supracardiac type. That's an MCQ. And also the worst prognosis, because obstruction is very likely in infracardiac type, the pressure in the pulmonary circuit is going to be very high, resulting in congestion and failure. So infracardiac type has got the worst prognosis, and the most common type overall, as I was telling you, is supracardiac type. So this is the slide showing the various types of total anomalous pulmonary venous drainage. You can see the first one. This is basically the opening of the pulmonary veins via the vertical vein into the superior vena cava. The second one is where it's directly opening the SVC. The third one is opening the right atrium, and the fourth one is going down and open below the diaphragm into the IVC. If you look at the percentages given in Nelson's Pediatrics, this is a table from Nelson's Pediatrics, and you can see supracardiac type is roughly about 50%. The cardiac type is around 25%. The infracardiac type is 20%. The mixed variety actually is some of them opening below diaphragm and some above diaphragm. That is known as a mixed variety. So overall, the most common type, as you can see, is the supracardiac type, which can be opening into via the vertical vein or directly into the SVC, or then you have the cardiac type, and then you have the infracardiac type, which is basically associated with significant obstruction. This is basically the amount of obstruction that is there, and you can see the maximum obstruction is in the infracardiac type. So this is another diagram showing the same thing. You can see it opening via the vertical vein, and when it opens via this vertical vein, what this will do is you have the ventricles below, and this vertical vein, via the vertical vein when the lungs are opening, this is going to create a shape like this, and this shape in the X-ray is what we call the figure of 8 appearance. Okay, this is because of the vertical vein pathway that is forming is going to create the shadow. The shadow that is created above is going to be looking like a figure of 8 appearance. So X-ray findings in anomalous pulmonary venous drainage is important. This called figure of 8 appearance is also referred to as a snowman's heart or a snowman's appearance. Okay, so X-ray findings is very easy to understand, mainly seen in the supracardiac type of total anomalous pulmonary venous drainage. Particularly the vertical vein that is there is going to create that kind of shadow above, and this is what I mean by it. And as you can see here, that this is the vertical vein pathway that is there in the SVC also causes some dilatation of the SVC, and this is going to be what we refer to as a figure of 8 appearance, and this is sometimes also described as a snowman's appearance. Okay, a snowman's appearance. So snowman appearance, figure of 8 appearance are important. They are seen in total anomalous pulmonary venous drainage. You can also see the pulmonary vascular markings are increased. This is a condition that I told you where the pulmonary blood flow is high. The blood comes to right heart, goes to lung, back to right heart, goes to lung, back to right heart. And remember I told that in anomalous pulmonary venous drainage, the atrial septum is not closed. So the blood across the atria shunts the left heart. That's how the left heart receives the blood. So the treatment that we do in anomalous pulmonary venous drainage is the pulmonary veins that are passing through behind the left atrium, we create an opening between the left atrium and the pulmonary veins so that the pulmonary blood flow drains the left atrium, and we close the atrial septum. This is how we normalize the circuit. So this is the corrective surgery that is done for total anomalous pulmonary venous drainage. Moving next to transposition of great vessels. The concept behind the transposition of great vessels I've already covered for you. This is a conotruncal septum that is not forming a spiraling course. In a non-spiral course is going to create two separate zones, that is the RV blood is connected to aorta and the LV blood is connected to pulmonary artery. So this is what you can see. This is transposition. This is also referred to as the detransposition. Which is the one that comes with cyanosis. So what you notice is the blood is coming through the right heart into the right atrium from SVC and IVC. The right ventricle is connected to the aorta because the septum spiral should have separated the LV blood into aorta and the RV blood into pulmonary artery. The septum spiral is here not forming a spiral course, and if it doesn't have a spiral course, it's just going to separate out RV blood into aorta and LV blood into pulmonary artery. So you see two parallel circuits instead of a series circuit. The blood comes to right heart, goes to aorta, back to right heart, and blood in the left ventricle goes to the pulmonary artery. From the pulmonary artery goes to lungs, from the lungs back again to the left heart. So instead of seeing a series circuit, what we're seeing is a parallel circuit. These children are going to have cyanosis immediately after birth, and the ductus plays a very important role in causing some amount of mixing of blood, but generally the ductus is not sufficient and the cyanosis is obvious in most of these children unless they're accompanied with atrial septal defect or a ventricular septal defect. So in general, most of these children who develop cyanosis in the neonatal phase, just the ductus patency may not be enough. We do give prostaglandin even in this condition, but one simple procedure that was developed by Rashkin is called Rashkin atrial septostomy. What is this Rashkin atrial septostomy is, we pass a catheter through the IVC into the right atrium, we pass it across into the septum, atrial septum, and we inflate the balloon. Once we inflate the balloon, we pull the balloon back, rupturing the atrial septum. We're creating a tear in the atrial septum. This is called atrial septostomy. This is a procedure that we do in the newborn phase itself, rather in the neonatal phase itself, and this allows good amount of mixing of blood across the atrial septum, right? So what are all the points that are important for transposition of great vessels? One is cyanosis occurs very early. Atrial septostomy is a very important technique that is done, developed by Dr. Rashkin. It is known as Rashkin's atrial septostomy. The X-ray is very important here. The X-ray is going to show egg on string appearance, or simply egg on side appearance. Okay, egg on string appearance on egg on side appearance. So to summarize once again, the things that are happening in the transposition of great vessels is, you should understand about the detransposition, the dextrotransposition. In this, what happens is the blood that is coming to right atrium, that is the SVC and IVC blood, enters the right ventricle. From the right ventricle, it is entering into the aorta. So from aorta, it goes to a systemic circuit and drains back again via the SVC, IVC into the right heart. So we're seeing then one circuit here. Left heart, left atrial blood enters left ventricle pumps through pulmonary artery. From pulmonary artery, it goes to lungs. From lungs, it drains back and then again comes back again to left heart. So you're seeing two parallel circuits that are occurring. The ductus plays a very important role in keeping the baby alive, but if the baby does not already have an atrial septal defect or a ventricular septal defect, we create the defect in the neonatal phase itself, and this is very easy to do. Pass a catheter in. Once you pass a catheter through the atrial septum, we inflate a balloon in. Once it's the cath is in the left atrium, and we pull the balloon out, tearing the atrial septum. This tear of the atrial septum allows mixing of blood between the right atrium and left atrium. This is known as atrial septostomy, Rashkin's atrial septostomy. The X-ray I was telling you is an egg that is lying on the side, or an egg that is hanging by a thread. This is called egg on string appearance or egg on side appearance. So this kind of looks like a shape of an egg. So egg on side appearance or egg on string appearance. You do notice the pulmonary vascular markings are high, and don't forget this is a cyanotic condition with increased pulmonary blood flow. So this is what I was telling you, the Rashkin's atrial septostomy procedure. It's important to understand that the corrected transposition or the L transposition will not have cyanosis. Okay, what we discussed up till now is the D transposition of great arteries. So one of the procedures that was done for transposition of great vessels was two surgeries were done. One is the atrial septostomy that we do, but once the baby is slightly older, obviously the best procedure is the arterial switch procedure. But for many years they were not aware of how to switch the coronary arteries between the two major vessels, and that's the reason why one of the techniques that they came up with is known as the Senning's operation or the mustard operation. Okay, Senning and mustard. So both these were done for the transposition of great vessels. Mustard and Senning. What is being done in mustard and Senning is whatever venous return is coming from SVC, IVC, the right atrial blood is getting diverted to left ventricle, and the left atrial blood is getting diverted to right ventricle. How this is being done is if we are using some synthetic material to create this, directional flow of blood, this is called mustard. If we use the atrial wall itself and mold it and fold it in such a way that the blood from the right atrium drains to left ventricle, blood from left atrium drains into right ventricle, then that is known as a Senning's procedure. So Senning mustard operations were the norm until they figured out how to switch the coronaries, and ultimately what we now have is we cut the aorta, we cut the pulmonary artery, and we do a switch procedure. And this switch procedure is also followed up obviously with a coronary transplant. So coronary arteries are removed and reattached. So this Jetin's switch procedure obviously is the best treatment that is there, but technically more difficult. So we have various treatment options that are there for transposition of great vessels. So let me repeat it once again. One of the immediate things that can be done is atrial septostomy, that is done in newborn state itself. The vessels are too delicate to do any kind of procedure in the neonatal phase, so whatever procedures we do much later. Later when we do the procedures, we have two operations, one is Senning's and mustard. Here what we're trying to do is create some kind of thing so that the atrial blood is diverted. These diversions are created from the atria. So right atrial blood is diverted to left ventricle, left atrial blood to right ventricle, and this allows the movement of blood in a series circuit. We also have the switch procedure, and the switch procedure that we're doing is known as the Jetin switch procedure, and this required the coronary switch as well, and that is now understood, and we are able to do this successfully. So it is known as the Jetin's switch procedure. What's remaining now is the truncus arteriosus. What you can see in truncus arteriosus is a common trunk. The conotruncal septum is not formed. The aorta and pulmonary are rising from a common trunk. And one important concept to understand here is that generally the valve leaflets that are there are more than 3 in number. So what you see is you can see 1, 2, 3, 4. So either they are 4 or they are 5 in number. So multiple leaflets are seen in a common trunk that is there. Left ventricle, right ventricle are opening in a common trunk that later divides into the aorta and the pulmonary artery, right? So this is the truncus arteriosus. So I was telling you what's happening in the truncus arteriosus is a common trunk is there. That common trunk opens into the aorta and the pulmonary artery. So obviously because it's a common trunk that is opening into the, okay, so this is left ventricle, this is right ventricle, common trunk opening the aorta and the pulmonary artery. So in this scenario the pulmonary pressures are going to be very high, and that results in pulmonary hypoplasia. Mortality rates are very high in an untreated child. So this truncus arteriosus, one of the few of the important questions that they ask is, one is about 33% of the children, 1/3 of them are associated with what is known as a mirror aortic arch, also known as a right-sided aortic arch. Okay, mirror aortic arch, also referred to as a right-sided aortic arch. Another most repeated question that you get over here is that you cannot have any benefit of creating a ductus arteriosus patency. Matlab, this is not a ductus dependent condition because already the blood is mixing nicely in a common trunk. Creating one more pipe between the aorta and pulmonary artery is futile. So this is not a ductus dependent condition. So they keep giving ductus dependent conditions are all except. So there are many conditions we discussed up till now. Many of them need the ductus for survival. This obviously will not have any benefit. They already connected to each other. So not a ductus dependent condition, truncus arteriosus. No point in giving prostaglandin E1 over here. Okay, not a ductus dependent condition. No question of A to B2 split. It's a single orifice that is opening at the aorta and pulmonary artery, so it's going to be a single S2. All these are important, and obviously the echo is going to show biventricular hypertrophy and the ECG is going to show biventricular hypertrophy. The right ventricle, left ventricle size is going to be equal because they're opening against a common trunk. When you look at the truncus arteriosus, then the truncus repair consists of creating a conduit between the right ventricle and the pulmonary artery and allowing the LV blood to be separated out into the aorta. So we are closing the ventricular septal defect by creating a VSD patch. The RV is connected to the pulmonary artery via the conduit. The LV is now moving blood directly into the aorta. So this is how we do the truncus repair.